We've got our special guests today, Wendy and Karen. Thank you both for joining us today for BRMC's Healthy Connections. And we're going to be talking about clinical and your documentation specialists. I'm losing words this morning. May have to dial back on that today. Wendy, tell me about what it is that you actually do.
Well, what we do is we review all of the patient's records for the physician and the nurse's documentation, and then we assign a diagnosis to that record, and we'll maybe question the physician if there's additional documentation needed or any clarification of documentation.
So this is pretty much after a patient has been admitted to the hospital, gone through whatever treatment that they needed, and then this is after discharge or just...
No, it's usually right as the patient comes in, usually in the first 24 hours we try to look at the chart, and then we continue to follow and re-look at it and see how the patient's flowing through the system and what's going on with them.
Okay. And go ahead, Karen.
I was going to say, we don't assign the diagnosis just in terms of what we think it is. We assign the diagnosis for coding based on what the physician has documented and has diagnosed.
Okay.
And what we do is for the most part to make sure that the record is compliant for billing under Medicare guidelines and under insurance guidelines. So what we do is more or less dictated by the regulatory guidelines.
Okay, so each diagnosis when a patient comes in, because a lot of the folks that watch the show may not understand sort of how the entire process, from the time you walk through the doors of a hospital with a need, from that time forward, what it is that occurs. So this is part of it. So they come in with pneumonia. That has what they call a DRG code.
Correct.
And that would be, once the physician has said, yes, this person has pneumonia, and here's the code that in the paperwork that they're going to assign to that. So, okay.
And along with that, under Medicare guidelines, they require certain wording depending on what DRG the patient is going to be billed under. And sometimes the Medicare language doesn't match up with the physician's language clinically, and part of our role is to get them in line with one another, so that the true severity of illness of the patient is reflected in the record.
Right, right.
So, for example, a patient might come in with an anemia, and we'll look at it, and then we'll ask the physician, well, what type of anemia is that? Medicare wants more specificity on that. Is it an acute blood loss? Is it a chronic anemia? So we'd like to get that more specificity just so the record is compliant.
How do you track down the physicians?
Sometimes that's a bigger job.
I was going to say that might be a challenge with their busy
cannot
schedule.
Hide from us, Donna.
Yes, they can run, but they can't hide.
Yes.
Okay.
Usually, initially, we will send them a message through the electronic medical record.
Okay.
There's an email system within that. And then most of the time we'll go up on the floors in the morning, try and catch them when they're rounding. If that doesn't work, then we are calling them over at the office. But we try not to do that because they don't like to be bothered over there.
Sure.
So we try to catch them up on the floor when they're actually seeing the patient and know the patient, and then have that conversation with them.
Does it help with the electronic medical records that they've gone into the CPOE that we've talked about on the show before, with a lot of the physicians jumping on board, learning more and more about electronic medical records and how to do their order entry kind of thing? Is that helping it with your aspect of the whole process, or?
Yes, I think it does help.
Yeah, that they're understanding a little bit better about all the codes and
and
why it's important.
The more comfortable they become with the electronic record, then the more they are coming around to answering us within the system.
Yeah. So, and you said that you go up to the floors and if you need to, track them down there and get the information that you need. And what other things then do you do?
Well, in our department, continuity of care, we have registered nurses and social workers. And what a lot of people may not realize, a lot of what we do is behind the scenes out of our department, but one of the key components of our department is discharge planning. And the social workers are the majority of the group that do the discharge planning with the patient and families to help set up services for after discharge. And they are in our department. And then the case managers, RNs, and Wendy and I both started out as case managers in our department. The case managers work with the insurance companies, the Medicare and Medicaid, to make sure that the patients are flowing through the system as they need to, getting the services they need, and are at the right status, if they're inpatient versus observation, what that means, and making sure that being in the hospital is the right level of care for them. They also work with the patient some in terms of discharge planning and making sure that the patient has what they need while they're in the hospital and post-discharge. So those are two main components of our department, but we all are RNs or social workers. There's 4 social workers. The rest of us are RNs, and I think there's 7 case managers and 3 RNs that are clinical documentation specialists.
Big department then.
It is a big department. And then we have a couple of other RNs that also are involved in record audits. If we have a payer, as in Medicare or an insurance company, that denies a claim for some reason, then they will review that chart and do what needs to be done with it to appeal the denial, or to get things kind of lined up if it needs to be rebuilt and that kind of thing. So we are more on the behind the scenes, with the exception of some of the case managers and social workers who work directly with the patients and families.
So they would actually go at some point in time up to the room and sit with the patient and sit with the family members, if there are any, and determine what needs to be done once they are allowed to be discharged, whether they need skilled nursing might be an option, or rehabilitation,
hospice,
home health.
Okay.
And one thing that people may not know, there is a social worker and a case manager assigned to every floor in the hospital. So if people come into the hospital, and I'm going through this right now myself with my mother, it's very stressful having a family member in the hospital or being in the hospital. And part of the goal of the case manager is to be the patient advocate. So they are a contact person for patient or family member on the floor, the social worker or the case manager. So when people come into the hospital, if they have questions, or if they have needs, or if they just need to ask questions and they're not sure who to ask, they can ask for the case manager or social worker.
So there's one assigned to every floor.
Yes.
Wonderful.
Yes, and then the 3 of us, the 3 documentation specialists, we work the whole hospital. We're not assigned to a particular floor.
So you just get out there and I just have visions of you running after doctors.
Well, we've been known to do that. There's been a few. It's like if you catch them when you can.
Yeah.
So we've caught them coming out of the bathroom or getting on the elevator. We'll ride up and down the elevator with them. We're not really shy.
We're not proud. We're gonna talk about this when no one's around.
And they're really very good. The doctors
they're
are
wonderful.
They are really very good and take it all in stride.
One day I met Dr. Lindsay in the parking lot. He'd just come out of his car and I was coming from administration. And I said, "Oh, Dr. Lindsay, I have a question for you." And I thought he knew me, and he said, "Well, who are you?" So we kept on walking and talking, and I got the answer to my question.
Yeah, but you were out of your element. You were in the parking lot.
Yes, I was in the parking lot. He didn't quite know me.
We are known as being stalkers.
Stalkers.
Somewhat. Yes, we keep our
no
eyes
restraining
open,
orders out against you
not yet,
so you're okay. I love it.
So, and the thing about our department too is that we have just a wide array of nursing and social work experience. And if one of us doesn't know the answer, we have other resources in our department.
Great resources to draw from,
and we know every community resource there is pretty much. So we truly view ourselves as being resource and advocate for the patient and the family. And our goal is to make the hospitalization a little less stressful.
Good for you, because that is just absolutely key. You know, oftentimes when folks are discharged, they're on the way to recovery, but they're not quite there yet. I mean, they may have, with home health or some other such thing, they'll be just fine. So, but they need to make sure that's in place. So,
correct.
Let's talk about that just a little bit more. We need to go take a break right now, but we will be right back. Don't go away. We're going to continue on with our discussion right after the break.